medicine and surgery a lot. So for example, like you're studying for like, let's say 4 to 5 hours a day, you should allot about 2.5, 3 hours to medicine and surgery, right? And rest 2 hours every day for this other topics, that is pedia, psyche, obs, and gynae and all, right? As the exam comes nearer, okay, as you approach the exam, it should be the other way around. Okay, you should just revise certain things from medicine and surgery, but then you shift your focus to the ones in which you're going to get the most of the MCQs from, right? And always, every day you must be, there should be a target that you should be solving a certain number of recalls. It's very important. It's very, very important, right? And that will also, so what I believe is your approach to, to go to this and to prepare should be retrospective. Now, what do I mean by retrospective is that you first solve the questions, okay, then you see the what the topic is it on. Like if you be solving, the very famous, all the question banks and everything, right? What question you're solving it from doesn't matter, but then you go to that topic and then revise it. It's always the better approach. That is where even all this, sessions like the recall sessions and all those courses are also very handy, because here we'll be having a main focus. We here also in my session today, we'll be using this retrospective approach. First, to solve the questions, then you go to the topics, and then then you explore more upon that. It should be an exploratory analysis. Then you explore more upon, okay, so in this topic, what are they asking upon, right? That is how it should be. Never go with the prospective approach that you'll just study the topics first and then you'll solve the MCQs. It never works, and you will be very exhausted, okay, in using this approach. So always move with the retrospective approach. So I think that is the one. Okay. So as we'll solve more questions, I'll keep on giving you the tips. Okay, so this is, I believe that you'll be having the recording for the session already. Okay, so there's no problem there. Right, you'll be having the recording for that session, right? And if you want, then you can also screenshot all this. So I have designated it accordingly. Then medicine, these are all the important topics. Okay, in surgery, these are the important ones. In obs and gynae, okay, the whole important topics, the child's health, the mental health. Okay, and also this is for your reference. Like when you're preparing and when you are even, doing recalls and all these things, it should be come very handy. So let's start with the first question of the day. A 32, wait. A 32-year-old man presents to ED with the sudden severe retrosternal and epigastric pain after repeated episodes of forceful vomiting following the heavy alcohol intake at a party. He appears distressed, tachycardic, and mildly hypertensive. On examination, there is tenderness in the epigastrium and the lower chest. You notice subtle crepitus over the supraclavicular area. This is a very important finding, right? And severe retrosternal epigastric chest pain, heavy alcohol intake. He appears distressed and tachycardic. What is your most likely diagnosis? Here, Mallory Weis-Steer, acute pancreatitis, esophageal variceal bleed, spontaneous esophageal rupture, or perforated peptic ulcer. Okay. Okay, so I think some are saying A, some are saying D. So we have between A and D. That is exactly how, that is how I framed this question as well. Right? This is all the questions that we were solving today, none of them are my own. Every question I've taken from the recalls only. Okay, so that is exactly, obviously, like, when you guys would have solved the recalls, the questions are, very incomplete. You only have like 2 to 3 options. So in that, I have made the options on my own. Most, like everything else, is from the recalls part only. So A and B. So how do we go about it then? Is it Mallory Weis-Steer or is it spontaneous visual rupture? What do you guys think? Or should be, so that is where you need to know. We have 2 tiers, that's true, right? I think the majority is going with the D. I can see some A's here and there, right? And that is definitely the right answer. It is spontaneous esophageal rupture. That is nothing but, changing the language of the question. Okay, over there they went with the Mallory-Weis-Steer. The sudden esophageal rupture is nothing but your Borheu's syndrome. Okay, Borheu's syndrome, right? So after the heavy alcohol intake, so we have all this, that we have the syndromes that we can discuss it over here. One is Mallory-Weis-Steer, another is Borheu's syndrome. Okay, see now, typically when we talk about all this, so what happens is that esophageal rupture topic in general, esophageal rupture. Okay, it's not just after alcohol intake. Okay, so over here we have actually A, B, and C, right? So A is actually your anorexia nervosa and alcohol. Okay, B is your bulimia nervosa. C is your caustic injury. Okay, this is the main mnemonics, right? Esophageal ruptures can be there because of all of those things, right? Less with the anorexia nervosa, because and sometimes, it's not in self-induced vomiting, but if such people, because they are very cacaxic, and if they have the vomiting, that can lead to the esophageal rupture. In bulimia nervosa, obviously it's a compensatory mechanism. We'll solve some questions I've included in today's session, and also it's caustic injury, like acid ingestion and all those things. So this is what may lead to the esophageal rupture. One important one is alcohol. So after alcohol consumption, we can have these two syndromes, which is Mallory-Weiss tear and the Borje's syndrome. Okay, so what is the basic difference? Okay, so this is mainly for the people who answered A. Right. So Mallory-Weiss tear, both of them are upper gastrointestinal tear, but the type of tear is different over here. It's very important to know. This one is simply just a mucosal tear, right? While the Borje's syndrome, it's actually a transmural tear, right? That is a transmural tear. So transmural tear is actually through and through, right? So that is including your muscle, your mucosa, your muscle, and also the serosa part, right? So it's through and through tear, right? And whenever this through and through tear is there, so obviously the esophageal air or whatever fluid everything contained would be, it would be leaking into the nearby areas, which is pleura. And that is exactly the reason why that Borjev syndrome is very, that is more concern of error, right? Melanovistia, over here you also you'll have see clinical presentations would mostly be the same. Here you also you'll see vomiting, you'll see retching. You might see because it's mucosal tear, no? So you can see some droplets of blood here and there. So that can lead to hematemesis, epigastric pain, all these things, right? Here in Borje's syndrome, there is a very, very important triad that we discuss. Okay, very important triad that we discuss along with, and that is your Meckel's triad. That's your Meckel's triad. Okay, so what actually happens in the Meckel's triad? One is obviously the vomiting part that is there. Second is the lower chest pain. And third is the subcutaneous emphysema. So why is there a subcutaneous emphysema? Because of the reason that I told you. Okay, because of the reason that I told you, that there is a transmural tear over here, and because of that thing, there is a leakage of the air and the fluid contents outside in the pleural space, and that is what causes this subcutaneous emphysema. So this is the main triad that we see, okay, for mediastinum, and that is exactly it. I've also attached this X-ray over here, and here you can mention that this is in the pleuritic space. There is which is also known as the Haman's sign. Huh? This is also important to know. There is a crunching. So see, subcutaneous emphysema, it's not like it only happens in the Borjev syndrome. Whenever there is any sort of chest trauma, okay, over there also you can see subcutaneous emphysema, right? And we go with the drainage part and everything. That's a different topic, right? So this is main that you need to know for Borjev syndrome, right? And what should be the lab or the imaging findings? So here, just simple endoscopy will confirm the diagnosis, right? But here you would need to do the CT or the contrast esophagography, right? You'll also do the chest x-rays, you'll also do the pleural fluid analysis, all these things, okay, you'll be having, because there is the pleural seepage, okay, the contents are being leaked into the pleural space, right? And the treatment, see, Mallory-Weiss tear, it's a conservative treatment, it heals spontaneously, you don't need to do anything, right? But here for the Borjev syndrome, you need to go with transthoracic approach, right? And you need to go with the surgery. That is the main difference. So but coming back to the question, you can see sudden severe retrosternal epigastric pain. That is actually the chest pain. There's also tachycardic, also hypotensive. So here there is systemic manifestations that you can see it over here. That doesn't happen with the Mallory-Weiss tear. In Mallory-Weiss tear, there are no systemic manifestations. It's just simple mucosal tear in which you will see at best the symptoms of hematemesis, nothing else. Okay. So that is why your answer is the sudden esophageal rupture. That is nothing but your Borje's syndrome. Let's move to the second question. A 64-year-old man presents with the recurrent episodes of severe central abdominal pain radiating to back. During attacks, he becomes pale, sweaty, and hypotensive, but recovers after several hours. The episodes have been occurring intermittently for 6 months. Between attacks, examination is unremarkable. What is the most likely cause? Lagging. Is it the same for everyone? Can you hear me and see the screen well? Because I've also, started that from my phone as well. Okay, and in my phone, is it the same for everyone? Do we have any technical problems here? Oh, you cannot answer like this, Dr. Salim, A/E. Okay, you cannot answer. Just choose one. Yes, legs are there. Okay. Actually, I'm not able to take the session from the usual place that I do. Okay, there was some little bit of an emergency thing, so I'm taking it from somewhere else. So I'm really sorry for that, but I hope it's tolerable. Okay, so tell me or tell me all the diagnosis in which the pain radiates to back. Can you tell me certain differentials in which the pain radiates to back? Uh-huh. Finally, someone has answered it correctly. Okay. Okay, abdominal aortic aneurysm, pancreatitis, then
If the
oh,
margin is crusty and yellow, yeah, you comment on it. Okay. If it's like dried
easy.
up, it's like an old wound that they probably picked the skin. It's going to be yellow and it's going to be dry. Yeah, you comment on whatever you see. Okay. Bayan, Shada, Rawan, Wujud, 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 Iyad, no, Rima, Rima Ali, Laura Amir, Lama Muatik, sorry, yeah, Ro'a, Ahlam, Shahad,
Who's
Salma,
this? Can you, do we have the
Aya,
team here? Can we mute
Ragad,
this person?
Juri,
Okay. I think someone else was also taking the lecture somewhere and has joined the session as well. That is what it seems like. Okay. Yeah, that's very good, Dr. iPhone. Perforated peptic ulcer, that is PPU. Okay. Here cases of cholelithiasis. MI also, you can, for that reason, you can consider MI. There's no problem with that. But better than MI, actually, I'll tell you, it is acute pericarditis. AP is acute pericarditis. Okay, so in acute pericarditis, that is actually how you differentiate the pain between pericarditis and the angina. So in the pericarditis, the pain radiates to trapezius muscle, that is back. While in the angina, it radiates to the arm and all, jaws and arms, that we know. Right. So you guys have been correct with the differentials. Okay. Okay, so here actually this is dominant aortic aneurysm, and I don't know why no one answered this correctly. Okay, right? See, what is happening over here, right? There is a recurrent pain, first of all, right? You guys, I think most of you guys answered the recurrent acute pancreatitis, right? Okay, but here you need to understand one thing. During attacks, he becomes pale, sweaty, and hypotensive. Okay, hypotensive would not be the feature that you more commonly see with the pancreatitis. That is one. Second, in 64-year-old year patient, suddenly having the bouts about the pancreatitis, very uncommon. Acute pancreatitis. See, this is the question why whenever you look at the question, you need to look at all the aspects of the question. Do you think the pancreatitis would that be common at 64 years old? Okay. Right. Even seen because mainly what are the main two causes of pancreatitis? Alcohol and gallstones, right? So if a patient is alcoholic, it's very likely that it will present earlier. And same is the case with the gallstones as well. Right. So that is one thing that also rules out the pancreatitis. And other is it also there are not such episodic pains for the pancreatitis. No, like it just happens and it recovers after several hours. It doesn't work like that. Pancreatitis patients they need to get admitted. Okay, right? I understand. I agree with that. It's an intermittent pain, but there is no such, hypotensive, being pale, sweaty, and all this. Such things doesn't happen in pancreatitis. There are no such systemic manifestations. It's only and only the pain. That is important to know, right? So that rules out your pancreatitis and everything. But also, someone also said biliary colicky pain. Okay, see, biliary colicky pain, that is mostly the pain that you see in the right hypochondrium. That is why I said that it radiates to the back. With the back, that is not. And yeah, after meal, that is also a very good point, right? So that rules out that as well. Ureteric coli, again, there is no such pain in the back, right? So that is the reason why it's in leaking abdominal aortic aneurysm, and that is your answer here. I hope that cleared everything, right? And I hope see AAA screening is very important. I have many questions planned up, and if we go at this pace, I'm worried that we won't be able to finish it up. But the screening guidelines of the abdominal aortic aneurysm, it's very important, right? Right, and how I say it's important. So if in the male and the female, it's different, right? So in the male, if it is more than 5.5, right, and in the female it is more than 5, then you need to go with surgery. And if it's lesser than that, then you need to go with the surveillance. Yes, we need to go with surgeon. If you go with the surveillance, that is by USD. Okay. Right, let's look at another question now. A 62-year-old woman presents with an abdominal distension, colicky pain, and vomiting. Abdominal X-ray shows multiple dilated loops as shown. She has an open appendectomy at the age of 15, so that is a surgical history. Most likely cause of her obstruction, right? So look at the X-ray and tell me, first of all, the baseline diagnosis of the X-ray and then the acute diagnosis. So what do you think it to be? No, it's different actually. Sorry, it's every 3 months, 6 months, depending on the size of the aneurysm, right? Okay, okay. It's SBO, very good, SBO, because there is, you can see central dilatation, central dilated loop. It's an SBO, very good. And there is already a surgical history, okay, of appendectomy at the 15 years of age, and that is definitely the post-op adhesions. Definitely, it's in post-op adhesions. Okay, that's correctly right. So everyone, I think, is right with this question, right? So these are the certain findings that we have at the small bowel obstruction. So here you see there is a central dilatation over here, right? So if you compare it with the large bowel obstruction, that we have the peripheral dilatation, right? So that we have the peripheral dilatation. In the small bowel, we have the central one, right? And depending on the guess, so what type of obstruction it is, we have different kind of findings, right? Right. So there is three different type of presentations in SBO. It can be if the gas it rises above the fluid level, or it can also be in gasless abdomen, or there can also be a string of pearls. There's three things, findings that we have. There is also an explanation to it, right? As I understand, this is not a lecture, so I'm not going into the detailed explanation of everything, right? But that is how it goes. And this is a very important table that you can also keep it as your last minute revision finding. So see, I'll just focus on the important topics, right? So with the small bowel obstruction and the large bowel obstruction. So here the small bowel obstruction, the most common cause is the post-operative adhesions, right? So the surgical history which was provided to us in the question, that's very important, right? So the post-op adhesions, also the hernias, the tumors, and the Crohn's disease. Right, but the most important one that you need to remember over here is the adhesions, right? And when we talk about the large bowel obstruction, so over there, the most common is the colorectal cancer, right? Colorectal cancer and also the sigmoid volvulus. That is also a very important cause for the large bowel obstruction, right? So out of these two, which one do you think? And there is also a toxic megacolon. There's also toxic megacolon, so that only happens in the colon part of the large intestine, definitely, right? But there isn't systemic toxicity, right? Right? Small and large intestine, both of them can be involved, but there isn't systemic toxicity that you can see it over here, right? Okay, and the colon dilatation that we mostly see more than 6 centimeter, right? So here, I don't think I mentioned over here. So see, there is actually the rule of 3, 6, and 9, right? 3, 6, and 9. So more than 3 centimeter if it is, it's small bowel, more than 6, large bowel, more than 9, toxic megacolon, right? So that is what we see it over here, right? And the systemic manifestation that we see it is obviously the inflammatory bowel disease, okay? The C. difficile colitis, Clostridium difficile, and also ischemic colitis. Ischemic colitis and all, that is also an important cause. So these are the main causes that we need to know. Obviously, the SBO can have a very sudden onset. LBO has the gradual onset, right? That is one important thing. Has the lagging and everything got corrected, or is it still the same? It's okay, right? Your the lectures is comfortable for you guys. I hope so. I just don't want to just keep speaking and speaking, and video is lagging. Okay, but what about the? It's going smooth. Oh, thank God. That message, thank you so much, Dr. Salim Javed. That made me really happy that it's going smooth. But certain, it's most of the time it doesn't happen, right? It's just 1 out of 10 times that it happens. And when it happens, it's very difficult from our end, right? Because certain technical problems, that is something that is not in our hands. And it can be a very big hassle. And we put a lot of efforts into making these sessions, right? And because of such laggings and all, if that session is not as good as I think it to be, then it also hurts me as well. Okay, right? So there's small and the large bowel that is and see in the bowel movement. So see here we have the constipation, but the flatus plus or minus, right? But in the LBO, there is an absolute constipation. So you need to look at clinical symptoms. This we call it as obstipation. So obstipation is absolute constipation. So here there is definitely no passage of your stools, but at the same time, no passage of flatus as well, right? So that is also the one point that we need to know, right? Right. So you need to know the causes, certain clinical symptoms and all. See, vomiting is also very important. The SPO, it's an early. manifestation. In LBO, it's a very late, or most of the times it's also absent. In LBO, you won't see
तो
much of vomiting. The management is
after rapid
also,
activity like for
guys,
apart
please mute your mics, everyone, right? Please, everyone, mute your mics, okay? Right? So, and yeah, if you want to speak something and if you have certain things to add, by all means, please speak. Please join the discussion. But for rest part, please mute your mics, right? Okay, so the early parts you have the vomiting, but in LBO that is mostly absent, right? So that is something. And see, the management also, see, SBO can be conservatively managed. Huh? If it's in partial or early part, you can keep the patient NPO. Both of the times, obviously, you're keeping the patient NPO, right? You can do the NG tube decompression in small bowel. But in the large bowel, because of the causes that we saw here, the colorectal cancer, the volvulus, and all, diverticulitis, if it's a complicated diverticulitis, surgical option, right? Let's move to next question. A 17-year-old girl reports a 2-month history of intermittent visual disturbances. She describes seeing shimmering, moving lights in both visual fields lasting 10 minutes, followed by a throbbing generalized headache that worsens with the physical activity. She feels nauseated during some episodes, but has no focal neurological deficits between the attacks. What is the most likely diagnosis? What's the most likely diagnosis here? Migraine with aura, okay. Someone is saying AMA versus Fugax. So you also explain what is AMA versus Fugax. What is AMA versus Fugax? That's actually, I'm not blaming you. It's a little bit, it's closest to the right answer. AMA versus Fugax is something that you see with the transient ischemic attacks or strokes. That's important to know, right? So in those cases, whenever there is a cerebral cause, right? So with there associated, you see the amaurosis, you get monolocular loss of vision. Yeah, but I think it's as simple as definitely it is migraine with aura, right? So there's a positive visual phenomena, flashing light, which lasts for 5 to 60 minutes, and then it's followed by the headache, right? So categorically, we have migraine with aura and without aura, right? So with aura, you have at least 2 headaches. With reversible, the aura can be any, right? It can be visual, it can also be sensory. You have the tingling sensation all throughout the body, certain speech symptoms and all, right? And if it is without aura, right, which is the most common type of the migraine, and you have at least 5 headaches, which lasts for 4 to 72 hours. But migraine, it's typical, right? It's unilateral, it's throbbing pain, it's pulsating pain, which can be moderate to severe and it is worsened by the activity, right? So this is classic for visual aura and not tumor or TIA. Hence, it cannot be amaurosis fugax, right? Let's look at another question. 52-year-old man presents with the sudden onset of the worst headache of life, right? That should itself give you the answer. That reached the maximum intensity within seconds while he was lifting weights. He vomited shortly afterward and now has neck stiffness. He is photophobic but conscious. So look at the picture. This is also the CT finding. What is the most appropriate initial investigation? Okay, see, and actually in the question, the CT was not given. I've given it for your reference, right? Because anyways, they're asking the most appropriate initial investigations, and obviously they will not give you the CT picture. SAH, okay. Rule out first, then other people. CT brain without contrast, okay. Then, okay, so there is the worst headache of life. Also, there's a component of neck stiffness, right? And that happened while he was lifting weights. That is also a very important component. Nocturnal, what is nocturnal? What do you mean here, Dr. Kaushalendra? Definitely, it is SAH. So tell me one thing. So what all do you consider as having the very worst headaches, very excruciating headaches? When I tell you that term, what all differentials does it come to your head? Migraine. Okay, you have the moderate to severe headache, but that's definitely it's not the you cannot say worst headache of life, doctor. Right? Trigeminal neuralgia. See, actually, trigeminal neuralgia, you don't have headache as such. You have the jaw pain and all. Cluster headache, that's a good differential, very good. Thunderclap, what is thunderclap headache? Thunderclap headache is nothing but Dr. Rashif, it's SAH only. Right, and SAH only you have it. Intracranial tumor, not so much. Giant cell arthritis, okay, it's giant cell arthritis, you have it. Right? Acute angle closure glaucoma, you have it. These are the very important differentials, right? Right. So see, definitely your answer over here is, I think, did anyone say C? Some people did say C. Yeah, yeah, yeah. Most of them say C. Some were confused with B and all. But it's CT brain without contract. So for hemorrhage, I think someone of you also defined this thing. Whenever there is a headache, you always give it NCCT first, right? NCCT first. And what is the reason? See, whenever you are thinking of stroke, even though there is no component of stroke, you're a hemorrhage for that matter. Stroke, we have ischemic and hemorrhagic stroke, no? Ischemic and hemorrhagic. Okay, so why first we should always do NCCT? What is the reason? We are not trying to reach the diagnosis. Okay, we want to categorize between the whether it's an ischemic stroke or a hemorrhagic stroke. That is very important, right? So when we do the NCCT, sir can give app meds. What do you mean by APP meds? Appropriate, APTs, yeah, it's appropriate medications. Yes, yes, that's true, right? So because we want to, because see, the management therapy of ischemic and the hemorrhagic stroke, that is completely different, right? It's anti-parallel, if you ask me, right? And what do you give it in ischemic, you cannot give hemorrhage. What do you give it in hemorrhage, you can give ischemic. Because in ischemic, you go with fibrinolytics, right? Can you give it an hemorrhagic? That will lead to more bleeding, right? So that is the reason why we go with the NCCD first. We are trying to rule out whether it's an ischemic stroke or an hemorrhagic stroke, and then accordingly we give the medications, right? So always on always first line imaging should be NCCD, and LP is only done if CT, if CT comes negative, then only go with the LP. Do not go with the lumbar puncture first, right? And obviously, like the patient is in so much pain, lumbar puncture also demands patient cooperation and everything, so you cannot just directly be like a little bit of oh yeah. Right? A 32-year-old man is brought to the ED by his wife because of increasing. Why not MRI before lumbar? See, CT comes. Do you think CT will come negative with MRI? Some ischemic, if not, you will have some hemorrhages, right? I'm saying that CT, if it's CT comes negative, then go with LP. If CT comes positive, then you can go with MRI because you want to see the exact location. And MRI also takes time. But that is not exactly what he's asking. I think what Dr. Salim is asking, after CT, what do we go with? After CT, why cannot we go with LP and then MRI? No, it's completely two different approaches. If CT comes negative, then only it makes point. Because see, why are you doing lumbar puncture? So look in meningitis or encephalitis, right? Okay, in meningitis and encephalitis, there won't be any changes on the CT. That's very important to know, right? So if the CT is negative, then only it makes sense to do the lumbar puncture, right? And if at all, then you're going with MRI, right? Yeah, I hope you got it. Right, let's move first. We are only on sixth question, and that is making me worried. A 32-year-old man is brought to the ED by his wife because of increasing confusion, drowsiness, and irritability over the past 24 hours. 3 days ago, he returned from a camping trip in rural Western Australia, where he spent most evenings outdoors near wetlands and reported multiple mosquito bites. He developed fever, headache, and malaise 2 days ago, while he initially thought it was just the flu. Today, he became disoriented and difficulty answering simple questions, vomited twice, no history of recent travel overseas. On examination, his temperature is 38.9 degrees Celsius, is confused, GCS is of 13, no focal neurological deficits, there is no rash, no rash. That's also an important finding. CT is also normal. What is the most likely diagnosis? See, now you will have such questions in AMC. Okay, please be ready about it, right? So before we discuss the answer, if someone knows the answer, please go ahead by all means. Okay, only the person who has solved all the recalls, only he would be knowing the answer to this. Because in our, routine lectures and all, we don't teach this thing because this is not normal. Okay, it is not normal, right? See, now, so yeah, like continuing what I was saying before, you will have such questions. Now, such questions, okay, I think only very few people will be knowing such questions. Like let's say like only like out of like say what 4 to 5 out of 100 people, right? Because they won't have studied this, and AMC knows this, so they just intentionally just put such questions, but never be much confused. Just go with whatever you think and don't think much about these questions, okay? Because these are not difficult questions, these are unusual questions, no one would have thought about it, right? So for the sake of asking, they can ask anything, and more likely than not, it's always from the infectious diseases, and it is not possible for you to study all the infectious diseases. Even I didn't. So until and unless I didn't solve this recall, even I didn't know about the diagnosis, the exact what is the explanation and all. Even I didn't know the answer to this, right? Even though I have studied a lot for the exam and everything, but I didn't. Right. So see, there's no point of discussing much more. This is actually Murray Valley encephalitis. This was a recent recall, and I wanted to bring it to your attention. Right. Right. So it is obviously mostly it's an encephalitis virus, which is cladi virus, right? And it's a mosquito borne, which is Culex species, right? And mostly it is in northern and the western regions of Australia. And early symptoms, you have the fever, headache, malaise, nausea, and vomiting, right? As like most of the encephalitic symptoms. And in encephalitis sign, you will see the confusion, drowsiness, seizures, focal neurological deficits, and all, right? And in the CSF findings, you will see the lymphocytic pleocytosis. Definitely, like in the CSF, when we do the lumbar puncture, you will see all this because it's viral, no? So I hope you guys know how to differentiate between bacterial, viral, and the fungal meningitis when we do the CSF analysis, right? That is important to know, right? So pleocytis, increased protein, normal glucose, and all that we see it in the viral one, no? Right? Diagnosis is obviously by the IgM serum analysis by serology. There is no specific antiviral, just supportive care, right? So after this, no, the only key point to this answer was Western Australia. So after, because they traveled to the Western Australia, it's specific to that, and the answer is Murray Valley encephalitis. Okay, so let's not so much waste much time on this. A 17-year-old girl is brought by her mother because she has lost 9 kg over 5 months. She eats very small portions, avoids eating with the family, spends long periods looking at herself in the mirror despite being underweight. She says that she still feels fat and compares herself unfavorably to her friends. Her periods have stopped. What psychological feature is most characteristic of her condition? First, tell me what is the diagnosis here? What's the diagnosis here? What's the diagnosis here? Anorexia nervosa. Yes, right you are. So tell me the answer. What psychological feature is most characteristic of a condition? Body dysmorphia. Yeah. So feelings of inferiority. Yeah. Yeah. Exactly. Because there isn't body dysmorphia. Easy question. A 22-year-old university student presents with the fatigue and palpitations, shows episodes of binge eating followed by the self-induced vomiting several times per week. Examination shows dental enamel erosion and mild parotid enlargement. So where do you see enamel erosion and the parotid enlargement? Tell me the diagnosis here. What is the diagnosis? What's the diagnosis here? First, tell me the diagnosis. Very good, right? You are in bulimia nervosa because of the compensating mechanism, right, of vomiting. So because of that, you also have dental erosion, parotid enlargement, and one more thing, which is Russell's sign. Okay, that is actually the pigmentation of the knuckles that we have, right? And because of the electrolyte abnormalities, no, there is hypokalemia, hypophosphatemia, and that leads to the compensatory tachycardia. So definitely the answer over here is tachycardia, right? Here. This is the basic difference between AN, anorexia nervosa, bulimia nervosa, and binge eating disorder, right? So there's a basic difference. In anorexia nervosa, the BMI would be low. In bulimia, it would be normal or overweight. In binge eating, obviously obese or overweight, because there is no compensatory mechanism here as such, right? And in the compensatory behavior, in anorexia also you can sometimes see it, yes. In bulimia also you can see it, but here there is no compensatory behaviors over here. That's important to know, right? And in the anorexia nervosa, see, mostly you have bradycardia, right? Right. So if you had to choose bradycardia, see, in both, that is the reason why both were not given the option. So brady and the tachycardia both can coexist. It's not like that, right? Here also the same thing. All the three metabolic classes, all these features, right? So the management is mostly CBT and SSRIs. 68-year-old man undergoes a transurethral resection of prostate, that is TURP, for symptomatic benign prostatic hyperplasia (BPH). Few hours after surgery, he becomes increasingly confused and restless. He then develops nausea, vomiting, and GTCS. His blood pressure is stable, but blood test shows marked hyponatremia, most likely cause of a deterioration. Mhm, mhm. right? I think it's a little bit easier because I've already given it, but it's important to know about the TERP syndrome. Okay, so see in TERP, what we do know, so when we are trying to resect that part of the prostate, okay, we do the continuous irrigation. Okay, there is three-way irrigation that we do it through transurethral. Okay, three-way Foley's insertion that we did over into irrigation. And because of such more fluids and all, it leads to dilution hyponatremia. Very, very good doctor, whosoever answered this. Okay. And that's dilutional hyponatremia. That is where in TERP syndrome, what happens? There happens confusion, that happens seizures. Okay, this is very important over here. This is because of hyponatremia. This is because of the hyponatremia. It's very important, right? 24-year-old woman with a known factor 5 lead-in mutation presents for the contraception advice. She is otherwise healthy, does not smoke, asks for the reliable hormonal method. What is the most appropriate method for contraception here? OCPs, vaginal ring, transdermal estrogen patch, POPs, or depot DMPA? Yeah, what should be the answer here? It's a little bit difficult so to understand. Mhm. Yes, what do people think? Yeah, definitely. It isn't progesterone only pills. See, so whenever we need to look at the VTE risk, which is venous thromboembolism risk over here, right? Okay. So see, I'll tell you both. These are the important tables. One is the combined OCPs, COCPs. Another is the POPs, progesterone only pills. So in COCPs, as its name suggests, there is also both the components of estrogen as well as the progesterone. In estrogen, we have the ethinyl estradiol plus progesterone. Here it's only progesterone, right? So the main action is because it inhibits the ovulation. There is an estrogen component, no? And in the progesterone only pills, it thickens the cervical mucus because of the action of progesterone, and it also suppresses the ovulation in because of this thing, right? So COCPs, they are mainly used for acne, dysmenorrhea, menstrual blood loss, all of things. It's better over here, right? Why? Because of the estrogen action, right? So even for this thing, for your PCOS, that also we go with this, right? OCPs and all, right? Right. But in the smokers, it is contraindicated. In smokers, it's contraindicated because of the smokers plus estrogen carcinogenic, right? In migraine with aura, again, because estrogen causes migraine, right? And breastfeeding also should be avoided for first 6 weeks because if the estrogen gets surpassed to the baby, okay, when they're breastfeeding, it leads to the precocious puberty and all, right? So in all these cases, it is safer to use POPs, okay? In the smokers and the migraine, people having the migraine with the aura or also with the breastfeeding. It's important to know this, huh, guys? Right? And also the VTE risk, venous thromboembolism. See, estrogen, it is hypercoagulable in nature. So that is the reason why we say that pregnancy, it's in hypercoagulable state because of the increased estrogen levels. Because estrogen has this coagulability nature, right? So already the patient who are at the risk of VTE, or even if you want to reduce it, in that we should not use with COCPs. Okay, it's better to go with POP. So the POPs we can say it is better. POP we can say it is better. Just 1 minute. Right? So for the POPs, we can see that we use it more for the PCOS. Also for the of the PCOS, we go with the estrogen ones, PCOS, dysmenorrhea, and all. But the POPs would be better for if because there is no VT risk over here, safer for the smokers, for the migraine with aura, for breastfeeding and all. Okay, this is also a very important table for we have the different classes of COCPs, no? With the monophasic, low dose COCP, drospirenone. Okay, drospirenone has a very high VT risk. That is why it is important to remember this thing. Then anti-androgen COCP again has a higher clot risk, multiphasic, traditional, and all. So over here, it is, I think, important to microginon. That is something that they ask. Yasmin is something that they ask. Microginon 30 they ask, right? So these are all the very common Australian brands, right? That is something that you should be knowing with. Right. Next question. A 52-year-old woman with obesity, type 2 diabetes, presents with rapidly worsening redness and pain over the lower abdomen. She was started on oral fluoxetine yesterday for presumed cellulitis. Today, the pain is severe, out of proportion to examination findings. Skin appears dusky with spreading erythema. Appropriate next step. But what is the diagnosis that you think it will be? What's the diagnosis here? What's the diagnosis here, and what should be the most appropriate next step? Mm-hmm. Okay, so what should be the next step now? Debridement, okay. Right. So, right, there is an urgent, it's necrotizing fasciitis, definitely, since you need to go with the surgical debridement. Okay, it requires emergency surgery. And you cannot just simply go with the antibiotics. That's important. 72-year-old woman presents with a vaginal bleeding 2 years after menopause. She has no pain. Examination shows vaginal atrophy, but no cervical lesions. Most appropriate next line investigation here. Okay, it's in post-menopausal bleeding, PMB. Okay. Most appropriate next line investigation here. Okay, mostly saying B, some are saying pap smear. Right. So first, let's look at post-menopausal bleeding. Yeah, biopsy is the right answer. So this is a very important topic. Okay, post-menopausal bleeding. Okay. So see, whenever there's a post-menopausal bleeding, okay, obviously, you do per speculum examination and all, right? See, there's a normal cervix, normal vagina, and all. So on that basis, you'll be able to rule out the organic causes, be it any cancer, any mass, any of those things, right? Okay. So now you need to look at the in ultrasound, you need to look at endometrial thickness, which is ET. So now you need to see that if ET is more than, sorry, less than or equal to 4 or more than 4, right? So if it is less than or equal to, see, if it's a more than 4, definitely you need to go with biopsy. If the thickness is more than 4, right? You need to go with biopsy. Certain times you also might need to do the hysteroscopy, right? If there's an insufficient sampling, okay, then again you go with the hysteroscopic evidence for the endometrial atrophy, right? And if there's sufficient sampling, then depending on the pathology, whatever biopsy results you have, you'll go accordingly. But if it's more than 4, you need to go with biopsy. But if it is less than or equal to 4, then there are certain risk factors that you need to know. And if such risk factor is present, then you need to go with biopsy. What are such risk factors? Older age group. Okay, so older age groups is HRT no use, because non-users of HRT. Because in the HRT, if the patients on HRT postmenopausal bleeding, it's actually the finding that you see along with that. It's irregular. So when you look at ultrasound, no, but it's an irregular endometrial thickness, or already there is an hemato or pyometra. Okay, pus or blood already is there. And here we can see that the age is 72 years old. So older women. So older women with postmenopausal bleeding, we need to go with endometrial biopsy. Yeah. Okay. 6-year-old boy has been soiling his underwear for daily for the past 2 months since starting school. Passes large hard stools every few days and avoids using the school toilet. There's no history of trauma or behavioral regression. Most likely cause. What exactly is this? What do we call this? Okay. After 5 years, if the child soils the pen, soils pants. Okay. What is this? Mechanical using? Mm-hmm. What is this? What do we call this? Encoparesis. Very good. Okay, and if it happens with the urination, it is enuresis, nocturnal enuresis. That is also happens in children. Okay, right. So what should be the diagnosis here? I'm saying C, some are saying D, psychological or positional behavior. Okay, See, every few days he's passing, that means there's an overflow. And when it happens, then he's passing all these large hard stools, right? Okay, so this is definitely an encoparesis. Okay, there is a fecal retention with overflow incontinence. So they'll try to just keep it in, keeping it until one day after 3, 4 days, there's an incontinence and they will pass. Okay, right. So these are all the differential diagnoses that you need to keep in mind. One is definitely the constipation with overflow incontinence, which is the most common cause technically, right? Heart builds up, leads to the leakage of the liquid fluid around the blockage. There is functional encopresis as well, okay, in which there isn't behavioral issues. That can also be the cause over here, right? But it's not very common. There's certain medical conditions that you need to be aware of, which is Hirschsprung's disease, hypothyroidism, celiac disease, or spinal abnormalities. All of that leads to the lumbar abnormalities in the lumbar plexus. It leads to the problem, spinal abnormalities and everything. And that is why you don't have it, the child doesn't pass the stool. Or certain psychosocial factors, like the child is having anxiety, stress to pass stools, at schools and all. That can also be the cause. But out of this, the most important and the common cause is constipation with the overflow incontinence. So that is important to know, right? And followed by the functional encoparesis, and the functional is just withholding. There's no behavioral issues, right? So I'm also give you for encoparesis, there's two main line of management. First is definitely establishing the regular toileting, right? So many toilet habits that you need to instill in your child. Okay, encourage them sitting on the toilet at least for 5 to 10 minutes after main meal or after school. But one particular time you need to do that. Okay, make also toilet a very interesting and a safe place. See, this points would be important to you when you're going to your next step, be it pesky or AMC clinicals, right? So you can put the posters over there, make it, make the child's washroom in a color which is, which is soothing to him, like pink color, bright colors, right? All these colors which the child likes, right? And make sure the child is comfortable on the seat. Okay, but they may need an inner seat. Okay, so you need to that give them the footstool, okay, so that they can comfortably rest, okay, while they are passing down the stools, okay, to ensure the child knees are higher than the hips, because then when that happens, when knees are higher than the hips, you can make more pressure, right? To encourage the child to lean forward, rest their elbows on the knees, because that also leads to, passing, gives a proper posture and proper pressure as well. Toileting diary, right? This is important. This they have asked before. I'm not included in the question, but this has been in recall. So if its age is less than 1 month, you can go with coloxal drops. If it is between 1 to 12 months, then you can go with the isoosmotic laxatives, which is Movicol or Osmolex, or even lactulose. If the age is more than 12 months, again, the same thing, or lubricant and all, you can also use it, right? So less than 1 month, there are certain drops available, which is coloxal drops. And with 1 to 12 months or more than 12 months, you can go with Movicol or Osmolex. Okay, there is different whole, in lectures I discuss this. What is the schedule and all for the Movicol, how you should be administering it, what dose and all should be. A 26-year-old woman presents 2 weeks after delivery. She reports poor sleep, low mood, loss of interest in the baby, and feelings of guilt about being a bad mother. She has no hallucinations or delusions and no thoughts of harming the baby. Most likely diagnosis here, postpartum depression. 2 weeks. Very easy question. Am I saying postpartum blues? Okay. Okay. So I think half of the people are saying postpartum blues, half are saying postpartum depression. What should we go with? Okay. One's also saying adjustment disorder. Adjustment less than a month. Okay. See, for depression, I hope you guys know. For the depression, okay, we have M side caps, no? The mnemonic, right? We have it. And that all the symptoms, okay, there is a loss of mood, sleep, loss of interest, guilt, loss of energy, concentration, appetite, certain psychosocial factors, and SS suicidability, which is M side caps. So you have 5 out of 9 of this nine. This are nine. So 5 out of this 9 for more than 2 or more than 2 weeks, right? Out of this thing, loss of mood and loss of interest are the essential characters, right? So here you're having everything. Poor sleep, you're having loss of mood, you're having loss of interest, you're having feelings of guilt, you're having. Okay, that is there for 2 weeks or more. 2 weeks, no? This is definitely just depression. So that is how you can diagnose this. Okay. I also tell you How do you differentiate between this thing, right? So see, postpartum, some people are saying, see, adjustment for the person who say adjustment disorder, okay, adjustment disorder, it's usually to the change in surroundings, right? It is usually in the change in the surroundings, right? And maybe a relationship, you break up in the relationship, or change in the environment and all, right? And that also happens 1 month after the change, okay, not 2 weeks later, okay, 1 month after the event. Okay, so see, postpartum blues, depression. So postpartum blues is typically 2 to 3 days after delivery only. Okay, this postpartum depression, it happens within 4 weeks, which persists for more than 2 weeks, because that is the definition of depression, no? Right? So blues, they start within 2 to 3 days and also resolves in 2 weeks, right? There are no psychotic features, there is function, everything is okay, there's no risk to the baby. There's only that, the mood is sometimes tearful, the mother is just overwhelmed, right? But depression, which happens within 4 weeks and persists for 2 weeks or more, with the symptoms that I just told you, that is MSIG caps, okay, right? So there can be certain possible neglect. There is also suicidal risk. So here you need to treat it with psychotherapy or SSRIs. Postpartum psychosis is a completely different spectrum here, right? That develops within days to weeks, okay, often in the first 2 weeks, okay, that develops in days to weeks postpartum. Okay, days to weeks postpartum. It is actually a psychiatric emergency, because there is the insight is lost of the mother. There is hallucinations, delusions, confusion, agitation, bizarre behavior, all these things. Okay, there's a high risk of the infanticide, suicidal risk is there, right? Right, and this delusion, hallucination, everything is present, right? So I hope this, on this basis, this is a differentiation you should know. 58-year-old woman reports an uncomfortable crawling sensation in her legs at night that improves with movement. She struggles to sleep. Blood test shows mild microcytic anemia. See, this because it's a recall, no? So this is the question stem is somewhat shorter. In the actual exam, they also give you all the different tests, which you don't even need to know for diagnosis, no? So to make the question stem longer. Here I've only included the important ones. So what is the diagnosis here? Can you tell me? What's the diagnosis here? Diagnosis, please. Very good. It is restless leg syndrome. Restless leg syndrome. Okay, so what should we go with? Next best investigation. Nerve conduction studies, some is saying, okay. Some is saying iron studies. Nerve conduction studies or iron studies. Thyroid function test. Okay, there's another one. Then they are developing this microcytic anemia, guys. Obviously, the answers would be iron studies, right? Okay, let me discuss with you certain parts of the restless leg syndromes now, right? So definitely the essential criteria is definitely used itself. It's urge to move legs due to unpleasant sensations, right? The symptoms begins, they worsen with the rest, but with the moment it's okay, but when you're at rest, you have this feeling to you move your legs. It's relieved with the moment, it's worse in the evening and the night. Okay. There is also PLMS, which is periodic limb movements in sleep. That is, the close association with the RLS. Okay, this PLMS. The PLMS is periodic limb movements in sleep. Okay, so it's in repetitive leg movements. Okay, some dorsiflexion, fanning of toes, everything which happens during sleep. Okay, it doesn't wake up the patient, it just disturbs the partner, right? So this is are the primary causes, and this is because of what, this is the primarily RLS or PLMS primary, for every pathology causes, primary and secondary. Okay, primary means there is no cause of it, it just happens on its own. So because of dopamine deficiency. Okay, it is more or less same like Parkinson's only. In Parkinson's also we have dopamine deficiency, it's same thing here, right? Certain secondary causes which leads to restless leg syndrome, and here your things come in pregnancy, in iron deficiency anemia, also when ferritin is certain drug like tricyclic antidepressants, SSRIs, SNRIs, and all these things, and also renal diseases and all, right? So on that basis, you can do these, common blood test. You can also thyroid. So because yeah, so someone was right to correct a thyroid function test. I'm not saying it's not wrong, because in the question it was already given it's microcytic anemia, but you know what happens with it's in hyperthyroidism. So in hyperthyroidism, what happens is the BMR is high. So that might lead to the shakiness. There is tachycardia, palpitation that leads to shakiness. You can consider doing TSH. Okay. Now this is the treatment. So obviously for the secondary cause of restless leg syndrome, you go with just treating the cause. But for the primary one, the treatment is just same like what we have for Parkinson is levodopa plus carbidopa or levodopa plus benzonaceride. Okay, all the dopamine agonist, again, pramipexole, ropinirole, okay, gabapentin and all that we use in Parkinson. So you can remember it like that. Okay, I hope this is clear. Oops, oops, oops. A 74-year-old man becomes acutely confused 24 hours after the open reduction of the femoral fracture. He's febrile, 38.5 degrees Celsius, tachycardic, mildly hypoxic. He's restless and disoriented. Which feature most strongly supports the fat embolism syndrome? Fever, okay. What were the people? What's the diagnosis here? What is leading to this? Oh, it's already given. I'm sorry. It is fat embolism. It strongly suggests fat embolism. Some is saying hypoxia. Okay. Hypoxia. Mm-hmm. Okay. Indeed, it's hypoxia because in fat embolism, it leads to long. So there is a respiratory compromise, no? Sometimes also leads to confusion. If that embolus reaches the brain, might also lead to the confusion. But the respiratory compromise is most common because it leads to, along with the neurological symptom, but respiratory compromise happens first, right? So that emboli reaches the lungs and it leads to respiratory compromise. Very good. A 23-year-old sexually active man presents with the dysuria and urethral discharge. He was treated 5 days ago with a single dose of the IM ceftriaxone for presumed gonorrhea. His discharge has improved slightly, but he now has a low-grade fever and persistent dysuria. Urine microscopy shows numerous polymorphonuclear leukocytes, but gram stain and culture reveals no organisms. What is the most likely cause of his ongoing symptoms? Resistant and gonorrhea, chlamydia trachomatis, E. coli, mycoplasma pneumoniae, or herpes simplex virus. So what's your diagnosis here, and what is the cause for that? Chlamydia trachomatis, okay. Chlamydia. Most of actually every one of you are answering correctly. It is see first it's obviously urethritis. So if there is no organism on the gram stain, that means a non-gonococcal urethritis. The most common cause which leads to the non-gonococcal urethritis, it is chlamydia, right? So differentiation between these two, gonococcal and the non-gonococcal, right? So the gonococcal, as the name suggests, it's Neisseria gonorrhea. Here you have the thick yellowish or green discharge. Yellowish or green discharge, and in the microscopy, you will see diplococci and neutrophils. And it's gonococci neurons. It's positive for gonorrhea, right? Complications, it leads to epididymitis or prostatitis. The first line treatment is very important to remember here, and that is, IM ceftriaxone plus azithromycin or doxycycline, right? Okay, so I am zone, F-track zone plus azithro or doxy. You need to, I have all this table, right? So if I have the access to you guys, I can also send. So there's like, for all the STIs and all, the management is very important to know, right? And see, there is also an abstinence advice. So there should be no sex. Okay, no sex for 7 days after the treatment. Okay, after the treatment, there should be no sex for just 7 days. That is a very important point to know. While it comes to the non-gonococcal urethritis, okay, the most common cause is obviously the chlamydia trachomatis, right? Here the discharge is different. You see, it's a clear or mucoid discharge, right? And here you see that there is no organisms on the ground stains, just leukocytes because of the infection. Increased WBC, that's it. And here the treatment is doxycycline for 7 days. Okay, so this is a key that I can give it to you. Pyuria plus no bacteria on gram stain, non-gonococcal urethritis. It's a chlamydia. Okay. A 74-year-old woman who has had several months of gradually worsening vision, which she attributed to cataracts. Okay, she now presents with the sudden painless loss of vision in her right eye. Examination shows a pale optic disc and hazy fundus view. She also reports scalp tenderness and jaw fatigue when chewing. Most appropriate immediate treatment. First, tell me what is the diagnosis? RAO, CRA or CRVO. That is what you think? Okay. Do you have the scalp tenderness or jaw fatigue over there, doctor? Central retinal artery occlusion or venous occlusion. And here there's a pale optic disc. Okay, so tell me what are the optic disc findings in CRAO plus and CRVO? Tell me that. Okay, okay. As the doctor has already mentioned that, let's discuss that as well. Okay, so in fundoscopy, it is pale retina, but they would give you there's no hazy fundus. There is cherry red spot that we see it, no, and vision loss is profound. But there is okay, right? And in CRVO, what do we have in the CRVO? There is a subacute painless vision blurring there as well, but there isn't blood and thunder. Okay, blood splash appearance over there. Blood and thunder hemorrhages. Yes, very good, Dr. Ashant. Okay, so that is not the case over here. There's also scalp tenderness. So some of you answered it correctly. Geez, it is giant cell arthritis, also known as temporal arthritis. Okay. Yeah. Okay. Right. So answers the okay. What should be your answer? No one told me the answer, I think. Okay. See, it is pretty small. Yeah, definitely. Definitely. It is GC. It is pretty small. Okay. So that there is no further. Because see, you can also reverse this vision loss and everything if PC prednisolone is given promptly. Right. Let's look at next question. A 10-year-old boy has started refusing school since his father remarried. 10-year-old. Teachers report no learning issues. At home, he is withdrawn, resentful towards his stepmother, but otherwise behaves appropriately. There are no symptoms of depression, ADHD, or conduct disorder. What is the most appropriate initial management? What should be the diagnosis here? Tell me, why cannot be, even if they have given it in the option, that's okay, right? Why is it, if I say, for example, if I, remove this thing, there are no symptoms, I remove this part from the question, okay? I remove this part of the question, okay? Is it ADHD? If it is ADHD, then what is the answer? Is it ADHD? Tell me. Is it ADHD or not? It's not ADHD. Why not? Very good, Dr. Rashif. Very good. So it requires two settings, at least home or school. They very categorically they are mentioning that at school it's fine. Teachers are reporting at school, it's fine. It's not at home. It's only at home because with a stepmother or not. Okay, then what is the diagnosis here? In this case, if that's the case, then what's the diagnosis here? Adjustment disorder. Okay, anyone else? Okay, so if it's adjustment disorder, okay, okay, okay. Then what should be the answer here? CBT, okay. Behavior modification therapy, okay. Behavior modification therapy. Think you guys corrected, it's adjustment disorder. But in adjustment disorders, we don't do all the CBT behavior modification and all that. It's not required. It's mostly in the psychotropic therapy. Yeah, that is the answer, Dr. Fatima. Okay, that's actually the answer. You go with the family therapy. Adjustment disorders, it just requires one-to-one counseling, one-to-one therapy, or certain therapies like family therapy. There's no need for CBT. See, CBT, don't use the term CBT quite loosely. Okay, don't say those terms mindlessly. Okay, right? CBT, we use it. It has got it's a very focused therapy, cognitive behavioral therapy. We use it for depression. We can use it for anxiety. We can use it for PTSD and all. Definitely not for adjustment disorder because adjustment disorder, it's not that grave of a disorder, right? So here you just simply go with the family therapy for adjustment disorder. Okay. A 35-year-old woman collapses at a restaurant shortly after eating. She felt dizzy. She felt dizzy, sweaty, nauseated beforehand. BP is 80 by 50. Okay. She had abdominal cramps and vomiting 20 minutes after eating a carrot containing dish. She has a history of seasonal allergies. What is the most likely trigger of this episode? So, what is the diagnosis here? And I'll just go one step further and also ask you what is the treatment also? What should also be the treatment? Anaphylaxis, yes, it's anaphylactic reaction. Specific seasonal allergies and all leading to hypertension, okay, cramps, vomiting and all, right? So, okay, IMADR. What is the answer here? What's the answer here? It's A, carrot allergy. Yeah, very good. Right? So exactly, we go with I'm adrenaline. Please remember the doses. This is important. Right? Zero point 0.5 mg. Yeah, you're right to answer. Who's this? Dr. Janthan. Right? So it is IM adrenaline, but you need to remember it's 1:1,000 dose, where we give it in the outer mid thigh. Okay. So this is also important that in less than 7.5 kgs, it's given zero point 0.1 ml. In 7.5 to 20 kg, it's given zero point 0.2 mg. That is something you can remember, right? Because the dose usually goes zero point 0.01 mg per kg. Okay, right? So for 0.2 mg, and then for 20 kgs or more, we go with zero point 0.5 mg of 1:1,000 IM adrenaline. Okay, and at the same time, the supportive management, you can also administer oxygen, 6 to 8 liters per minute. Okay, establish the IV excessive hypotensive, IV bolus you need to give. NS, it was hypotensive, no? Here also in this case also it was hypotensive. So 20 ml per kg, that's a dose. You should give the IV bolus over there. Right? There's an airway obstruction all. You can give NEM adrenaline here as well. Salbutamol puffs and also you can also give it here. Right? Hmm. Second last question. A 35-year-old woman has three first-degree relatives with the cold colorectal cancer. One diagnosed at the age of 38. She already has started regular colonoscopic screening. What additional step is most appropriate? What additional step is most appropriate? This is a good question, actually. Colonoscopy screening has been started. Okay. Refer to family cancer clinic. See, why? Because here, three first degree relatives, no strong early and early family history, early onset family history. So here, that was diagnosed at the age of 38. That's still early. So early family onset history strongly suggests the Lynch syndrome, right? So genetic counseling again, special reference needed. So at the same time, I'll also give you this colorectal cancer screening here as well. We have to rule out, yeah. So see, in that you guys would be knowing these are the most updated guidelines for the colorectal cancer screening. We have three categories, category 1, 2, and 3, right? So category 1 is either you're having no family history or one first degree relative who's diagnosed at the age of 60 or more, right? So your main screening test is you go with the IFOBT, right? You started at the 45 to 74 years, right? And FOBT, you should do it every 2 years, right? And see, low dose aspirin, it's actually LDA, not LOA. My bad, there's some typo there. It's LDA, right? So you should give a low dose aspirin, okay? Every, you should start with that. So this typing error. Okay, low dose aspirin you can start in these patients. Okay, what is category 2 now? In category 2, you have either one first degree relative at the age of 60, less than 60 years, or one first degree relative plus one or more second degree relative at any age. Means two relative history is there. One first degree relative, okay, any age, it's okay. And once one or more second degree relative, but at any age, or two or more than two first degree relatives at any age. So here, main, you need to start with colonoscopy, right? But here you need to know earlier, either you can start at the age of 50 or 10 years younger than the youngest diagnosis. So if I tell you that, my like uncle, first degree relative was diagnosed at the age of 54. So 10 years younger is 44 or 50. I have two options. Then you should start the screening at 44 years of age, right? So this is important to know that you should start at the earlier onset of either 10 years younger or the age of 50 years. Okay. And you can do it. This colonoscopy should be doing it at every 5 years, right? And if the colonoscopy is declined, you will go with CT colonography. And category 3, see, category 1, it's near or slightly above averages. Category 2, it's 2 to 4 times more than the average risk. And category 3 is 4 to 20 times more than the average risk. So in the category 3, you have two first degree relatives and one second degree relative, okay, with one diagnosed in less than 50 years of age. Three, no, it's category 3, so three. Two first degree relatives and one second degree relatives less than 50 years of age, or two first degree relatives, or two or more than two second degree relatives, two, or three or more than three first degree relatives. Okay, here also you should go with colonoscopy. Here the same thing. Age is 40. You should start with the 40 years, either 40 years or either 10 years younger than the youngest diagnosis. Okay, that colonoscopy you should also be doing it every 5 years. Okay, this is important to know. Colorectal cancer screening. Last question. An 82-year-old man presents with a pearly nodule on his back that bleeds whenever it is rubbed by clothing. Slowly enlarged over the 1 year. There is central ulceration with the rolled edges. Best management. First, tell me what is the diagnosis here? What's your diagnosis? PCC. Very good. It's PCC indeed. Very good. Okay. So what should be the answer here? Excisional biopsy. Excisional biopsy. Yeah. Very good. Basal cell carcinoma requires surgical excision. Excisional biopsy. Okay. Okay. One more. One more for melanomas management. A 32-year-old woman presents to your clinic for the skin checkup. The examination, she is found to have a skin lesion on her upper back. The lesion is highly suspected of being melanoma. An excisional biopsy is performed with 2 mm margins, and the specimen is sent for the lab for the histopathological studies. The results shows melanoma of 2.5 mm in depth. The margins, however, are clear. Which of the following would be the next best step in the management? Now tell me this. Answer for this. Okay, one saying A, then okay, most are saying wide excision. Yeah, very good. So you see here, this is something that you need to know, right? Okay, but margins for the second excision, that is very important. Right, so every lesion is suspected of the melanoma should be surgically excised within 2 mm margins, both as initial management, also there is an appropriate next step in the diagnosis as well, right? And then you might need a wider excision, right? So see what happens here, if it's a melanoma in situ, this is just, margins of the second incision, just 5 mm. That is just sampling that you need to take it. If the depth of the lesion, this is best flow thickness, by the way, BT is best flow thickness. So the depth of the lesion is less than 1 mm, only take 1 centimeter, 1 to 4 mm. Okay, minimum 1 centimeter, maximum 2 centimeter. So 1 to 2 centimeter you can take. And if it is more than 4 mm thickness, then you need to go with 2 centimeter of the wider excision. So for melanoma greater than 1 mm in depth, a sentinel node biopsy is recommended during the second excision to assess the potential metastasis. This is nothing but this is a wide local excisional biopsy. Right? And depending on, see, this they will ask in the question. So here it was given 2.5 mm, You should take how much should be taken? 2 centimeter of wide local excision should be taken. Okay, that is how it should be taken. It's very important. That is, right. So that is it. Was not asked in this question, but they might ask it in that way. Okay, so that marks the end for this session. I hope you guys enjoyed the session. You found it to be fruitful. Okay, you also got to know about the recalls and the crash course. Okay, our team will get in touch with you for regarding the information regarding the courses as well. They are also putting it in the chat if you want to get in touch with a counselor. Right, thank you so much. I hope you guys liked the session. If you have any doubts, please do let me know. Right, you can also send me your feedback. How did you like the session? Thank you so much. Thank you. Did you guys like the session? Did you find it fruitful? Was it okay?